Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, access to buprenorphine in pharmacies. Dr. Jeff Hom is the Medical Officer for Science and Policy in the Substance Use Services section of the San Francisco Department of Public Health, and Marlene Lira is the Senior Director of Research at Workit Health, a multi-state telemedicine treatment provider for evidence-based addiction care. Both doctoral students at the Johns Hopkins Bloomberg School of Public Health, Jeff and Marlene, talk with me about how local pharmacies like CVS and Walgreens can be vital parts of the opioid response by dispensing buprenorphine, and the regulatory framework that both helps and sometimes hinders their ability to do so. Let's listen. Marlene Lira and Jeff Hom, thank you so much for joining us on Public Health on Call. Today, we're talking about addiction treatment and pharmacies, and specifically about buprenorphine. So, Jeff, why don't you start off by giving us an overview of this medication?
Sure. So buprenorphine is a medication for treating opioid use disorder or opioid addiction, which is often characterized by strong cravings for opioids and uncomfortable withdrawal symptoms when those opioids are absent. And it's that desire to avoid withdrawal symptoms that prompts people with severe opioid use disorder to continue using opioids, like heroin or fentanyl, because most people with severe opioid use disorder aren't using to feel high. They're using not to feel sick. Buprenorphine eases those cravings and withdrawal symptoms, and in doing so, it can help people stop using non-prescribed opioids. It's one of 3 FDA-approved medications for treating opioid use disorder. Most people take it 2 or 3 times a day as either a tablet or a dissolvable strip, though it can now also be given as a weekly or monthly injection. Like methadone, which is another one of these FDA-approved medications, buprenorphine can reduce the risk of dying by 50%. And that's remarkable. There's really not another medication that I can prescribe for a chronic illness that's associated with such a life-saving benefit. But there are some differences between some of these FDA-approved medications that I do want to mention. Unlike methadone, which can only be dispensed from specialized clinics when treating opioid use disorder, buprenorphine can be prescribed in a variety of settings, like in primary care, emergency departments, or through telemedicine. And importantly, buprenorphine can also be dispensed from retail pharmacies, just like medicines for high blood pressure, high cholesterol, asthma, or diabetes. There were previously some laws that limited the prescribing of buprenorphine, but these were changed by the federal government a few years ago. And these were changes that were made specifically to make it easier for providers to prescribe the medication. But really, increasing the prescribing doesn't do much if the medication can't be picked up in a pharmacy. And that's why thinking about pharmacy access is so important. But at the end of the day, buprenorphine isn't inherently special. We have decades of experience with it. It should be available in every retail pharmacy, just like other medications, so that people with opioid use disorder really can get it when and where they need it.
And we've covered this before on the podcast, but I just want to ask a clarifying question. Some of the reasons why it was harder to get access to buprenorphine was less about the potential for misuse or anything like that, and more about stigma. Is that correct?
That is correct. Stigma remains a challenge, I think, in many different aspects of our overdose crisis. That includes the medications that are used to treat opioid use disorder and substance use disorders. They can indeed be difficult to get due to stigma.
And Marlene, would you talk to us about access from pharmacies? I'm assuming this might mean a local CVS or a Walgreens?
Yeah, absolutely. So patients can fill prescriptions at retail pharmacies. It could be CVS, Walgreens, but it can also be at independent pharmacies. And in August, I was part of a team that published a study looking at pharmacy access issues among patients receiving telemedicine treatment for opioid use disorder. We wanted to understand what was going on in pharmacies and what the experiences were of these patients. So, to set the table, I work at Health, which is a multi-state telemedicine provider for addiction. We deliver care virtually across the country, and our model is focused on low barrier access to evidence-based treatment. And one of the silver linings of the COVID-19 pandemic was that it allowed telemedicine models like ours to expand. For people with addiction, telemedicine can provide enhanced privacy, reduced stigma, and it can help reach patients in rural and underserved areas. But pharmacy access remains one of the biggest hurdles. In our study, published in JAMA Network Open, we surveyed more than 600 patients in 5 states who were receiving telemedicine treatment for opioid use disorder. And we found that nearly 1/3 of patients, 31.9%, actually reported going without their buprenorphine at some point in the past year because of a pharmacy-related barrier. And of those who went without buprenorphine, a quarter reported going 7 days or more without the medication. The most common problem cited was that pharmacies didn't have buprenorphine in stock and they needed to order it. There were other types of barriers as well, like insurance issues or hesitancy toward telemedicine prescriptions, but by and large, not having buprenorphine in stock was the largest problem. And importantly, these pharmacy problems were not limited to rural areas. Patients in both rural and non-rural settings had these issues that they reported. And so the takeaway is really that pharmacy barriers are widespread and they create dangerous gaps in treatment.
What happens when people can't get their medications?
Yeah, so for patients, the consequences can be both immediate and devastating. If someone receives a prescription from a medical provider but then can't fill it, withdrawal can set in within hours. And as Jeff alluded to, withdrawal is pretty miserable. People can develop anxiety, muscle aches, sweating, chills, hot flashes, runny nose, trouble sleeping, and then very quickly it can progress to nausea, vomiting, diarrhea, and stomach cramps. And these symptoms are all accompanied and exacerbated by intense cravings. So when this happens, people are not necessarily thinking about long-term recovery. They're just trying to stop feeling sick. And that's why individuals might return to fentanyl or heroin if they can't get their buprenorphine right away. On top of that, when a pharmacy doesn't have the medication, patients and providers are often left scrambling to find another pharmacy that has it in stock. This takes coordination between the provider, the clinic staff, and the patient, and sometimes across multiple cities. We actually had one patient who had tried 5 different pharmacies before finding one that could fill their prescription, and that pharmacy was over an hour away by car. So every month they had to drive over an hour each way, so 2 hours round trip, in order to fill their prescription. And experiences like these have been the catalyst for several innovations within our practice. We've created a database of pharmacies where we've had success in order to help our staff and our patients navigate these challenges. And we've also partnered with several pharmacies that can actually ship buprenorphine and offer home delivery. But time is really of the essence here because every hour that a patient goes without medication raises the risk of return to use. So at best, pharmacy barriers cause delays, but at worst, they mean, treatment dropout, return to fentanyl use, which puts people at extremely high risk of overdose. So this isn't like waiting an extra day for a medication for cholesterol or another condition. Missing a dose of buprenorphine can really mean the difference between staying in treatment or falling back into a cycle of use that can be deadly.
You mentioned that just having this in stock is one of the biggest problems. And so, Jeff, you've done some work on this.
Yeah, absolutely. In San Francisco, we'd heard from patients like the one that Marlene mentioned of having difficulty getting their buprenorphine from their pharmacy, which, as you heard, this difficulty results in delays at best, but really missed opportunities and harmful consequences at worst. And our data in San Francisco backed that up. So we did a secret shopper survey in the summer of 2024 and found that just 29% of pharmacies in San Francisco had the medication in stock. And that was really troubling. So in the city, we had a naloxone ordinance in place requiring pharmacies to stock and dispense naloxone, the antidote to opioid overdoses. And we felt that an important extension to that policy was to require retail pharmacies in San Francisco to stock buprenorphine. So this ordinance, which is the first of its kind in the country, does just that. It requires pharmacies to stock buprenorphine, and it went into effect a year ago in September of 2024. And the goal of the ordinance really is simple. We just want to make sure that when somebody is ready to start treatment with buprenorphine, the medicine's available without delay. Specifically, our ordinance does require retail pharmacies to stock enough buprenorphine to fill ongoing prescriptions plus 2 new prescriptions, each for 1 week. And if these are dispensed, pharmacies are required to restock them, thereby ensuring ongoing access to the medication. And I think this ordinance reflects the city's commitment to normalizing access to buprenorphine, and we hope it inspires broader adoption of policies that really can increase receipt of this life-saving medication.
Who's responsible for enforcing this minimum stocking requirement?
In San Francisco, we believe in this medication, and we believe access to it should be reliable and predictable and citywide, and we believe in this ordinance. Our ordinance does allow the health department to enforce the law as needed, including through notices of violations and fines for each day of noncompliance, which, as you can imagine, really adds up very quickly. But really, our goal is not to be fining pharmacies. Our goal is to educate and empower our pharmacists in the city here. So we're really committed to education and collaboration. And I think we view our pharmacists as partners in today's overdose crisis, just as they were during the COVID-19 pandemic. So while enforcement and fines are a possibility in San Francisco, we first want to be as supportive as we can and help pharmacists feel knowledgeable and confident in talking about buprenorphine with their patients and are indeed in compliance with the law. So to help educate them about the medication and the ordinance, we've mailed letters, we've sent faxes, we've given presentations to pharmacists and pharmacy managers. And later this month, we'll be hosting a continuing education program for pharmacists in San Francisco. And I'll say that, we've seen progress without having to pursue enforcement so far. Our survey shows that stocking rates have increased, and that's encouraging. We're not where we want to be yet. I think, this change does take time, especially with something new like this ordinance. But the good news is we are moving in the right direction. We recently heard from one of the large pharmacy chains in the city here that now all of their stores do have it, whereas they were previously around 50%. And anecdotally, it's improved as well. So I do feel like this is all good news.
That is great news. On this show recently, we've been talking a lot about the role that pharmacies can play in public health, and this is just another great example. So, Marlene, I want to ask a tough question now. Who's paying for all of this? How are these initiatives supported?
Yeah, so there are multiple funding streams that all contribute to addiction treatment. So Medicaid, Medicare are big payers in this space. There's also a lot of money that's coming into local governments from the opioid settlement agreements that have been intended to increase access to addiction treatment. But this problem is actually pretty complicated. And ironically, the opioid settlement agreements have added a wrinkle to this specific issue. And while this challenge has been around historically, it's pretty tough right now because of some of the provisions of the opioid settlement agreements. So a recent study in Health Affairs found that between 2017 and 2023, less than 40% of retail pharmacies in the country regularly dispensed buprenorphine. And while the settlements were really meant to hold companies accountable and fund solutions to the crisis, they also put some guardrails in place that have been creating some unfortunate unintended consequences. So pharmacies and distributors are under really intense scrutiny for the volume of controlled substances that they carry. And distributors often cap how much controlled medication, which includes buprenorphine, a pharmacy can order because they don't want to trigger federal oversight. So this has a downstream effect of making pharmacies and pharmacists really nervous, understandably. even if they want to carry more buprenorphine, they worry about crossing these thresholds or skewing. Sometimes they refer to these ratios of controlled substances to regular medications because they don't want to trigger audits and greater scrutiny. So strangely enough, we've ended up in a sort of paradox where the policies that have been designed to prevent the overdispensing of opioids are actually blocking access to the very medications that treat opioid addiction. So there's this really interesting and unfortunate complication that's adding a wrinkle to these local and state issues around buprenorphine access. And some states are trying to fix this. So, for example, the Michigan legislature is currently considering a state law, Senate Bill 403, that would require pharmacists to fill addiction medications without undue delay. And then a bill that was considered in the 2025 legislative session in New Mexico and was really inspired by the San Francisco ordinance would have introduced minimum stocking requirements. But going back to the idea of payment, there are some payment things that could be considered, right? The reimbursement rates for buprenorphine are pretty low, especially for Medicaid. So states could consider increasing the reimbursement rates that pharmacies get for dispensing these medications. And they could also think creatively about using funds from the opioid settlement agreements to create designations or awards of excellence to pharmacies that go above and beyond and really try to help people get access to these care. So there's both a lot of money coming in that could be used in creative ways, but then there are also challenges with funding and the regulatory environment on top of that.
Well, you're highlighting a lot of solutions, but you're also saying, there's still a lot of work to be done. Any final thoughts on this?
I'd end by saying, to pharmacists, to policymakers, and to the public, that buprenorphine is an effective, evidence-based medication for the treatment of opioid use disorder. And stocking it at a pharmacy is no different than stocking insulin or antibiotics. It's really just simply good patient care. I think our vision in San Francisco with our ordinance is that every person in the city with opioid use disorder can get buprenorphine without delay at any pharmacy. And I think we should aspire to that as a country.
Jeff Hom and Marlene Lira, thank you so much for joining us on Public Health on Call.
Thank you for having us.
Thanks for having us.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Michael Bonfils, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production coordination by Catherine Ricardo. Analytics by Elisa Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.